This conference will now be recorded.
All righty. Well, good evening, everybody, and welcome to the AnCan Active Surveillance Group. This is the Active Surveillance Group. So if you are presently being treated or you have been treated, this is not the proper place. You're more than welcome to stay, but we have other groups that would be better suited for your needs. We are the BPH group, if that's one of your problems, which undoubtedly for some of us, as time rolls on, will become a problem. Hopefully not. But anyway, first and foremost, we'd like to thank the sponsors who will help make this possible. And that would be Novartis, Telix, Blue Earth Diagnostics, and Foundation Medicine. Without their help, this would be extremely difficult, especially since we have about 33 support groups at this time. So without further ado, we have two new people with us tonight, Dave and Milton. So I'm going to turn it right over to Dave. Okay, and you are going to converse initially with Michael, who's going to ask you some of those questions I talked about. Go ahead, Michael.
Okay.
Hey, Dave. I'm Michael Williams, one of the moderators. Tell us where are you at? Where do you live at? Where are you diagnosed at?
I live right outside of Philadelphia, and I was diagnosed. I go to Jefferson Health.
Okay. How did you hear about AnCan? How did you know about us?
One of my neighbors actually runs a prostate support group, prostate cancer support group locally. So he got me in tune to this group also.
Very good. And I would encourage you to, participate in your local group too. I'm in more than one group myself. Have you signed up with AnCan on the website for reminders and put your information in, email and such?
I haven't. Since this is the first time.
Okay. Right. If you want to give us your email, in the upper right corner, there's a couple of little square spots, and you can always put that in the message right there and give it to everybody, or you can send it to one specific person or one of the moderators if you want to, if you
Okay.
want to keep it private. Tell me how old you are.
I'm 58.
Okay. Are you a veteran by any chance?
I am not, no.
Okay. So when were you first diagnosed with prostate cancer, and how did your diagnosis come about?
My father has had prostate cancer. He's been treated with radiation, and it's been successful. Probably about 20, 30 years ago. He's now 94. But my PSA kept rising at some point. And then I'm trying to read the notes here, back in 2020 is when I had my first transrectal guided biopsy. And then I got a Gleason score of 6.
Okay. Since then, have you had repeat? That's 2020. Have you had repeat biopsy in 6 years, or?
I did, yeah. I just had one in 2024. And came up with a 6 score also.
Okay, that's good.
And back in 2022, I had a TURP procedure done.
Okay. So where is your doctor? Where are you being seen at? Are you in the community? Are you at a major university or center of excellence?
It's Jefferson Health. It's right outside of, they have affiliate, different hospitals, different offices all around the Philadelphia area.
Okay. And apologies, I think you did say that before. I'm not that familiar with Jefferson Health, but I think I have heard of it some. What about the other guys here? Are we familiar with them? Do we know anybody there?
I don't know that we know anybody, but I know that they've been talked about previously.
Okay.
What about your teaching hospital affiliated with the University of Pennsylvania?
Okay. Um, what about your PSA history? Where's your PSA been running?
Just recently in February, it was back up to an 8.3.
Okay. Are you trending that? Have you been looking at it? Some of us are lucky enough to have a electronic medical record system where you can actually look at all your past PSAs and see where they're coming and going.
Yeah, I have them here. So after I got my TERP in 2022, which was probably like September, October of 2022, they did a PSA in January of 2023, and it was down to a 1.2. And then
Okay.
2024 in September, it was a 4.5. And then it went up to a 6.4 in 2025. And then now it's at
Okay.
8.3.
And have you so correct me if I'm wrong, you've had at least two biopsies, and did
Yes.
they do a biopsy when they did the TERP on that at that time too?
Yeah, they took out whatever they took out, they tested, and it was benign.
Okay. And what about how you said the first biopsy was transrectal? What about since then? Was the second biopsy a transperineal or
No,
guided?
transrectal.
Both of them were?
Yeah, both.
Okay. Okay.
I asked
Go ahead.
I asked about a transpernal, and they didn't offer that one.
Okay. We are great proponents here of not doing transrectals. If
Okay.
we can possibly, sometimes people we find are restricted due to health insurance or something, but
Right.
there is some risk of infection and really severe infection and what we call sepsis. So, we always try to push people in that direction. What about your MRI? Have you had a MRI done?
I had one MRI done before my second biopsy in 2024, and that was benign.
No lesions at all on it.
Right.
She
Okay.
didn't have a previous MRI.
Not the first time, no. From when I had my first biopsy, they didn't give me an MRI before it.
Huh.
That was in 2020. Is that when you had your first biopsy?
Yeah.
Well, we've come forward a long ways with that. In 2020, we found a lot of people were not having MRIs, but thank goodness we've moved forward with that in a lot of cases.
And you said your MRI, it didn't show anything?
It came back benign. It says benign 23 cc gram.
So yeah, so they didn't see anything.
They didn't see anything, right?
Dave, did they give it a PIRAD score? Do you see something there that says PIRADS, PIRADS?
I don't.
They didn't see anything, so they wouldn't have a
It would be,
pirate.
yeah, it would be a 1 or a 2. When they don't see anything, Mayo still gives it a PIRAD score. So that's great news. That's what you wanted to hear. So that's terrific.
And how many cores, Dave? How many cores were positive?
In my last biopsy, I'm trying to read it here. It says the GI, it says GI 3 + 3 = 6 in 6 out of 12 cores, up to 45%.
Oh, 6 cores were positive with Gleason 6.
Yeah.
And it doesn't show anything on the MRI.
Right.
Sorry, I had to turn this walkie-talkie on. Excuse me, guys. So
Andy.
did they see any any other characteristics in your biopsy cores like cribiform or perineural invasion or anything like that? Is there anything noted like that in your
I mean, it's
biopsy?
a large printout, so I'm not exactly sure.
Did you get a second opinion on it?
I have not, no.
Okay. We're going to put in the chat where you could get a second opinion on that. We're big proponents of getting a second opinion on any pathology. You could still get it.
And are you so you've been with the same doctor for 6 years? Is that correct?
No, it's not correct.
Okay.
I switched doctors. I believe it was in 2024 or yeah, because of insurance reasons.
Okay. All right. Like he was saying, you know, we do try to push people in the direction of getting second opinions on their biopsy results, particularly if you do have a high number of cores positive and you want to get them looked at again. I mean, we find it's not unusual at all to see a change in the gradings of these things, sometimes downward, when you get the second opinion.
Mhm.
And you know, Gleason 6 is generally if you're going to have a score, that's the one you want to get. You know, it's not associated with metastasis or spreading. So you know, it sounds like what is your doctor pro active surveillance?
Yes, I'm on active surveillance.
Okay.
Okay.
What
Also-
about have you had any germline or genetic testing? Looked at any inherited characteristics?
I'm not exactly sure.
Okay. Sometimes they'll do a test named Prolaris or Decipher, or there's another GP test they do. Have you heard any of those words or seen any of those tests done?
I've heard, I believe, some of them. I'm kind of new to all this, in terms of participant, especially this group participating.
Well, that's what you're here for, is to get educated, and
Right.
you will get educated. It won't all happen in one night, so be patient with it. And you'll
I
every
understand that.
every time you come and listen, you'll learn something. Everybody's got a ton of experience, and you know they can help you out with that. I'm going to say right now, you know, I think it's important with your history with your father that you talk with your doctor about getting some genetic testing,
Mm-hmm.
and to make sure there's not a gene there that concerns you. You know, it's also good for your offspring, your children, to know that, to give to them too. And how are you feeling? How are you doing personally with this?
I've been okay with this. And a little recently, after I got my PSA back, in February with the 8.3, I was a bit concerned because it keeps rising. My doctor, she's not as concerned, just because my PSA's kind of been high all along. But I'm going to get my PSA done in another 3 months in May.
Tell me the size of your prostate again. How large was it?
I guess the volume 24.
After the TERP, it was 23.
Yeah, 23 cc grams.
It was after the TERP?
Yeah, that's after the TERP. That was in December of 2024. That's when I had my MRI.
Okay.
Is that
and I'm gonna ask
large?
you, did you run that PSA density?
No.
I'm getting a 3.3 something.
3.36.
Yeah, that's what I got. Okay. So
Well, we
what-
got a couple
what-
of hands up. Let's see what Andy and Dan has some hands up. Andy, why don't you, you got a question for Dave?
I do. Dave, welcome.
Thank you.
I'm wondering, does it show only on one side with all these biopsies or on both sides?
It's, I mean, I can't really show it, but you know, it's more, I guess, if you're looking at it's more to the, I don't know if it's the right or left, but it's, because depending on how you're looking at it, I guess it's the right side. There's more cancer in those cores.
The pathology list out in the individual cores and where they were taken from?
Yeah, it has the different cores and, you know, the base, mid, apex.
There you go. So
It's
yeah,
all,
that
it's all mapped out. I can't really show it. I mean,
hard to tell, you know. So you're not sure if it's bilateral, unilateral.
I mean, it says lateral on the chart, but
Yeah,
Yeah,
you
that's
just have your different lobes in your prostate, and so it's always good to find out. You can ask your doctor, you know, is this just one side or the other, or you know, he could show you on a diagram.
I,
That would be a good thing to know.
they can show you, Dave. They have generally they use a grid pattern if they weren't aiming for any particular spot, and usually they start at a number of 12 in that region of biopsies that they take, and they know
Right.
where each needle went.
right, that's what it's showing on the diagram.
But do you have dots like basically in 4 quadrants, or they all seem to be on one side, or they're scattered
They're
around the diagram?
They're mostly on the right side.
Okay.
There's some
And
on
then
the left.
There's one on the left.
Okay,
Like it's called the base left.
okay.
Okay.
I mean, can
Thank
you,
you.
I know it's a small camera, but it's really,
We can kind of see it highlighted there.
Looked like you had medial. Sometimes right is left and left is right, depending upon. It'll tell you, I think, on that drawing.
yeah, it says right.
When
Okay.
you get a
looks like
chance,
that-
maybe after the meeting, when you read each core, the description of where they went and what was the volume of the Gleason 6, it should tell you basically where it came from. That's, you know, right now that's not overly crucial. 6 is a good number. That's what you want to know. And with the number, I don't know who we put up for pathology, most likely Dr. Epstein.
There.
They're all there. Epstein's,
Yep.
a whole bunch of stuff
We
for second.
want to tell you that those are the best guys in the business. All they look at is prostate pathology. Dr. Epstein was actually Dr. Zhao's teacher. Dr. Zhao was a student of Dr. Epstein. They are the absolute best on the globe to the best of our knowledge. So we're reiterating about, and of course we don't get any money from them people either. We just know that they're the best, and that's the best that we can do for the people that are in this group. So I just wanted to, nobody mentioned who they are, what kind of credentials they have, but they are the best to our knowledge. Dan, what do you got for Dave?
So I want to go back, talk a little bit about the family history. So Dave, your dad was about your age when he was diagnosed with prostate cancer, yes?
A little bit older, in his 60s. Yeah, but
Yeah.
close.
are there any, does he have female like sisters, cousins, mother? Was there any cancer in the women on his side of the family? Breast cancer, ovarian cancer, anything nasty
Not-
like that?
I mean, he had 6 brothers, not to my knowledge, but I can find out more.
Did any of his brothers have prostate cancer?
I don't believe so.
So you might ask your dad if he ever had testing for BRCA1 or BRCA2, and if he didn't, it might not be a bad idea because you're pretty young, and so there are some of these genetic mutations that people carry. I'm a BRCA1 carrier. There are some of these genetic mutations that can get passed down and cause people to get cancers a little earlier than say other people.
Right.
As Gary said, Gleason 6 is a good place to be because while you have cancer, Gleason 6s almost never spread to other parts of your body, and as long as the cancer is in your prostate, it's considered curable. So, but the problem we're having is that your PSA has been going up while the volume of your prostate is very small. 24 cc prostate is small. 90 is big.
Mm-hmm.
And so if you divide your PSA by the size of your prostate, you come out with something called a PSA density of 0.36, which is higher than we like to see it. So, I want to ask you a couple of questions about your PSA testing. You're aware that there are certain activities and things you're supposed to avoid before you have your PSA tested?
Yes.
And you've been good about that?
Yes.
Okay, so no sex, no bike riding, none of that kind of stuff.
Right.
No
Correct.
bike riding while having sex, none of that stuff. Okay. And then have you been going to the same lab for your PSA testing?
Yeah, LabCorp.
Okay, so you're not switching different labs because that's, there's some inconsistency in the numbers they come up with. So I think, I think they got a little nervous, which is why they recommended a biopsy in 2024. As long as your PSA is below 10, you're still considered in the lowest risk group. So, but if it keeps creeping, my guess is that they'll probably want to order another PSA. Are you doing all the right things in terms of diet and exercise and all the stuff that they tell us to do?
I'm eating pretty well lately, yes.
Fine, pretty well. For Americans.
Yeah. I've been doing a lot of plant-based, I guess kind of gluten-free. Not
Yeah,
as
gluten
much,
has nothing to do with this.
right, but just for health reasons, and also just a limited amount of meat, very nominal.
Okay, yeah. So plant forward diet is recommended. Maybe dairy, red meat out, that kind of stuff. And what about exercise? You doing any exercise?
I do work on my feet, so I get exercise that way, and I do hike, occasionally. That's also.
Okay. Well, there's been a lot written about the benefits of, strength training with either bands or weights or even calisthenics. So you might want to look into something along those lines, even though you're doing physical stuff during the day. We're just trying to think of all the things we can do to get your PSA to calm down a little bit.
So Dan, one thing that strikes me with Dave is the idea that the MRI isn't showing anything.
Yeah, MRI doesn't show Gleason 6, and that's good. That's the way it should be. If he had Gleason 6 and had a lesion on his MRI, then we'd say there's something doesn't fit. So MRI is not designed to show low-grade prostate cancer.
Yeah, but you'd think that it'd be showing something with 6 cores.
Yeah, that's what the MRI guys say is, we don't see low-grade prostate cancer, and it doesn't seem to bother them because low-grade prostate cancer doesn't kill people. So they're willing to. they're willing to accept that. But
Yeah. So I think it's be important for him to get a genomic test.
well, we're talking two different things here. You want him to get you don't want him to get Polaris or one of those.
You bet.
Those aren't actually in the NCCN, algorithm for working up, low grade group 1 prostate cancer. It's only for people who are like 7s and, wanting to know which side of the border they're on. But if he's a straight 6, and he's been a straight 6 now twice, even though he has a fair amount of positive cores, but
with that rising PSA, I think that getting a genomic at this point would be helpful.
Yeah.
Well, it could be for his peace of mind. It may be within, not within the medical guidelines, but I think the point you was trying to make is that for his peace of mind, get a genomic test. I actually think with his father's history, as Dan pointed out, the genetic right now supersedes the genomic to make sure that he doesn't have a mutation and he BRCA1 or 2. So I think
Dave, you could ask your doctor about a genomic test and see what he thinks.
Okay, all right.
So what we're
genomic,
so Dave,
yeah,
what we're talking about is the BRCA1 and BRCA2 tests are mutations that you would carry in every cell in your body. The genomic tests are for tests of mutations just inside your prostate cancer. And they tell us two different pieces of information, but they're both important. I would probably talk to your doctor about those.
Okay.
Okay.
Ray, did you have your hand up?
Yeah, I did. Dave, just two. One's a comment, one's a question. Do you have your MRI report there?
I'll have to look.
The question is what type of machine it was done on the MRI, and did they do it with contrast where they gave you an injection?
I believe so.
Okay. And does it say like 1.5 T or 3 T? Do you see that anywhere?
I don't see the test.
The type
The
of
result.
machine. Okay.
I mean, I might have them somewhere else. I'm not sure.
The other question, the other comment was LabCorp does have a couple different assays for PSA. Usually it's the Roche assay that's typically done, but I would just look at your blood test to make sure it's all the Roche, because there's a difference as to what the numbers come out if they use one assay versus a different, even from the same blood sample.
Okay.
Hey, Dave, real quick. I got a sense, because if I was sitting in your seat, I would be overwhelmed right now, because you got everybody asking you 1,000 questions, giving you terms that you haven't heard before. We're all trying to help, but we want you to take a deep breath and keep coming back, of course. Keep coming back to us on each Wednesday. But I don't want you to get overwhelmed. I just want you to see that this is what we do. This is how we interject to try to make everybody understand about your situation and to make comments. But I'm sure you're getting a little bit overwhelmed, and we don't want to take your anxiety from I'm okay with it to like, oh my God, what am I doing? You're good. Your numbers are good. You're in a good place. You're in a great place with us. Just some of the information we ask for, try to gather it, for the next meeting. And if you don't understand it, gives you a little time to do Mr. Google and find out what the hell we were talking about. If you didn't fully understand it, I just got a feeling that maybe you're getting a little overwhelmed, and I just wanted to tell you, just, take a deep breath. Your numbers, whatever you got going on right now is okay. And one thing about this disease, you've got time. You've got time to make decisions, and you can make decisions when you have all the information, when you feel good about all that, and you can be the best advocate for yourself. Okay, so just keep it at that. All right.
Yes, that was going to be my question, that there's so much information, and I'm kind of better when it's one-on-one with somebody, or, just to kind of go through all this, like at another time, if that's possible, somebody.
You bet. Put your, if you don't mind putting your email in there, and I'll send you an email, and you can reach out to moderators anytime.
Okay, and where do I put that? I'm kind of,
In the chat. You see the, if you look up in the upper right corner, and you see, looks like two little folders.
right.
If you click on that, it's called the chat.
Okay, I got it.
And then it says send a message if you put your email there.
Dan, did you have any more questions for Dave?
I just wanted to reiterate what you said, Gary, which is that, you know, we're throwing a lot of stuff at Dave. It can be a little overwhelming. This is like taking dance lessons. You don't get it on the first lesson. And, but, you know, understand that despite all our questions and concern, you're still in the lowest grade group of prostate cancer. And as Gary said, you've got time. There's nothing going to happen tomorrow or even next week or even next month. So you've got time to discuss this with your doctor, to talk to Dr. Google and sort things out and keep coming back, and things will start to sharpen up in terms of focus and what's important and what's not.
And believe it or not, Dave, in the very near future, you could be asking the questions to the next new guy. So there you go, because that's how it works. So you just hang in there and it's all good. I know that Ignacio, I think, had his hand up. Ignacio?
Yeah, just Ignacio, forgive me. I just want to say one thing on this. I think we need to be really careful when we send people to Google, because you need a degree of education when you go to Google, or you can go right down the rabbit hole. And
Like I was referring to, for instance, if you looked up the words PIRAD, he would get a simple explanation with the 5 words, and it would tell him it goes from 1 to 5.
Okay, Gary, but
1
we have
being
to,
low, 5 being high, right?
right. But we have to say, we have to say that.
Have to say that.
We have to say what we're talking about, because we have so many people that go to Google and they go and they pull out stuff that makes them very, very nervous. And you know what I would say, and what we should do, is we should send Dave maybe the NCCN early diagnosis for patients folder or something like that, which has the definitions in it. Because Google, to me, is a very, very dangerous source. Okay. We have way too many people who come in and they say, well, this is what I saw. I went to Dr. Google. This is what I saw. So I think we've got to be very, very sensitive about how we use Google.
Okay.
I don't know how other people feel about that.
All right, so I wanted to offer Dave some words of hope, and I will not be sending you to Google. I'm going to be sending you to YouTube. There is, I had the opportunity to attend the PCRI conference, and I believe it was in 2024 that I attended a talk from Dr. Klotz, Klotz, who is renowned in the field of active surveillance. And in fact, I believe he's considered the father of active surveillance. But what stood out from the talk is a statement he made that if you have lesions that are not visible in the MRI, those tend to be non-aggressive. So the fact that they can't be seen on the MRI is good news and highly hopeful. I encourage you to see if you can find the talk. It is available online. And again, it's from Dr. Klotz and PCRI Conference 2024.
Excellent, excellent. That would be helpful, Dave.
Okay, I wrote it down.
Okay.
Put my email out there if anybody has information. I would appreciate it. And
I don't see it. I don't see your email come through. There you go.
There it
I got
is.
it now. Okay.
That's right.
Got it.
Dave,
is there-
I'll send you, right now the NCCN document. NCCN is a major body that oversees, that represents all of the, many of the best hospitals that treat cancer. And I will send you, don't read beyond the active surveillance part, but read the active surveillance part. It'll help you as a good primer to get you comfortable with the terms, if nothing else.
Dave, I just sent you my email address. I'm one of the moderators, and I'm not that far ahead of you. I'm only about a year. I've been this recently, so send me an email. We can work a time to get together and talk through a lot of the issues that you're working.
Okay, thank you.
All right, Dave, do you need anything else? I think we kind of filled up your plate there. It might be overflowing a little bit, but like I say, just take a deep breath. Time is on your side, and if you've got to be somewhere, where you're at is okay.
Yeah, my only question is, I mean, since I'm new to this group, like, and I have a Gleason 6, and if this is an active surveillance group, when does it like flip to not active surveillance, or like what's typically a Gleason score that you would then have to have some type of procedure or whatever?
We can talk through more of that if you want to offline.
Okay.
I think once I start talking, you'll understand, because I believe I'm past the active surveillance, but I'll let you guys decide that.
Okay, Dave.
Okay.
Anything else? Can we help you with anything else?
Dan's got his hand up.
Oh, okay. Sorry, Dan.
And
Yeah, since this is Dave's new to this, I just wanted to tell him that 6 is the lowest you can get. 10 is the highest. If you're a 10, you need treatment. If you're 9, you need treatment. If you're a 7 or 8, if you're an 8, you probably need. If you're a 7, is when things get a little confusing. But 6, you're definitely in the right. You're definitely in the right place with active surveillance, and you have time. I know a lot of people have mentioned, but to follow up what Ignacio said, there was just a video posted on YouTube by the PCRI guys, a guy named Dr. Scholz, SCHOLZ, and he talks a lot about the different Gleason scores, what they mean, what the percentages in each biopsy, what it means. And he's very clear that he's never seen a 6 that's gone on to metastasize anywhere. So if you want, that might be reassuring, but it's good for him to explain the different numbers and what they mean. You might learn something from that.
Okay.
Just came out 2 days ago.
Okay, Dave, we're gonna move along. If there's anything else that comes up during the meeting, just raise your hand and we'll get back to you. Okay.
Okay, sounds good.
Okay.
Thank
All right.
you.
Real quick, before we get to Milton, we had a couple people jump on late. BJ, good to see you. Do you need any time if it's available this evening?
No, I'm good, guys. Thank you so much. Actually, I have to drop off, but it's good to see you guys.
Same here. Have a good evening.
Thank
Joe
you.
Ingrone, are you out there in the up there in Canada?
I'm gonna tune in here. I just wanted to join in. It's good to see, Gary Hugh.
Yeah, it's good to see. It's good to see you. Do you need any time if we've got some?
Well, I saw my urologist. I have a urologist story, and it has to do with the challenges of staying on active surveillance when you're a grade group 2. So I thought I was going to relay that, but I don't. But I may have to cut out because my sister-in-law is going to be coming for dinner, and my wife went out to get groceries, so I have to man the door. So
okay. Well, we've got a new guy.
You may not get to me, but if you have time, I'd like to talk about that.
Okay. If not, please come back. We haven't seen you for a while. It's good to see you, Joe. I hope everything.
Yeah, it's good to see you guys. Glad you're still all at it.
Yeah, we're at it. Okay. All right.
Gary, I just want to do a quick promo. I'm just about to put it in there, but later on tonight, at 7:30 Pacific, about less than an hour after you'll finish here, I am going to be interviewing Greg Burns, who is well known to many people in this group because he spent a long time in this group before he was promoted to the low intermediate group. And I know the moderators know, but he's a pretty well-known person, and he's a Paralympian, 3 Paralympics swimming. He's a renowned artist. He's a motivational speaker, and he's a friend of the Komodo dragons, right, Gary?
Yes, he is. And he
And
likes to hang out in Bali. So good for
and he
him.
likes to hang out in Bali. So I am going to be interviewing him live. It will be recorded, but I'm going to be interviewing him live. And I will put the link, and it's free. It's drop-in. When you get to this link, you can choose to join the Zoom call or to come in through YouTube. But it should be fun. It's a program we do with the Marsh Theatre Company.
Okay. All right.
Gary, before we move on, Levin had his hand up.
Yep, we're just going to get to him. Go ahead, Lee.
Okay.
Yeah, this is just kind of, I have a question actually, I realized it just now, and I think it's related to what you were also advising Dave to do. So I actually contacted Dr. Epstein for a second opinion on my 3+4 from my first biopsy. And I'm not sure if I'm doing things right. I just filled out the form on his website, and that's kind of a week ago, and I haven't really heard anything back. So it's just a practical question here if I need to do anything else.
If you've talked with him before, I'd go ahead and try to call him and follow up.
So I haven't talked to him at all. So but and I don't know if there's a phone number on the website. Maybe I can look that up. Yeah.
And
I think there is a phone number on the website, but let me look.
Andy, you got your hand up. Did you have something related to this?
There's a phone number on his forms, and there's an email that you can email him, and he's usually quite good about getting right back to you, since I don't know what you have for your phone system. That would be a rather a long distance phone call for you.
Yeah.
But he's usually pretty easy to get either way, but there should be a phone number on that form you filled out.
Okay. Maybe I just
The other
missed it.
thing I recommend you do is contact the pathology lab directly that has your slides, and tell them what you are trying to do, and find out from them exactly what they need and what form it needs to take. And that will help the process go faster.
Okay, great. Thanks. Yes, thank you.
Michael, you want to
Yes, sir.
introduce Milton to the group?
Yes, sir. We'll start off with Milton. I'm Michael Williams. I participate in the group here, and I'll try to go through a few questions with you if that's okay.
Sure, and I probably can go forward with this. My name is Milton. I live in Rochester, Minnesota. I am a hospital coder for the Mayo Clinic Laboratory Business Office. Prior to that, I was a phlebotomist at one of the hospitals here at Mayo for 10 years.
Milton, let me interrupt. Would you allow us to follow our process, because we have questions that we like to ask in order?
Sure.
And that way it works quicker for us. So let us ask you the questions.
Thank you,
Go
Rick.
ahead. Go ahead, Michael.
Milton, how did you hear about AnCan? How did you come to
Online.
find us? Okay, good. Have you signed up online for our reminders for our groups? And
I filled out something, and then this Bill responded because I filled out a form, stated who I was, what I was interested in, and included my email, and he responded, and he told me about this group.
Okay, good. I think you'll probably be on the reminders then.
Yeah.
And they usually come out on Monday to remind you of this meeting.
Right.
How
That's
old?
Bill Franklin that he spoke with, Michael.
Yeah, yeah. How old are you, Milton?
I'm 64.
64. Okay. You're a young fella. Are you a
Yep,
veteran by any chance?
I am not.
Okay. Okay. Um, when you were first diagnosed with prostate cancer, how did this come about? What started your journey?
Um, in August of 17, my PSA was 4.6. In January of 18, it was 4.9. My provider thought that leap was a little bit much. On January 23rd of 18, I had MRI with contrast. It came out as a PIRADS 1, no cancer seen.
Okay.
Then in August of 19, my PSA went to 5.3. October of 20, 5.5. And then I kind of dropped out. I didn't see my doctor for a few years.
Okay.
Then May of 22, 7.3. January 10 of 26, 7.4. I was sent to a urologist, MRI on February 5th, 2026 with contrast, PIRADS 4, volume 485.1, density 0.16.
Okay. I'm gonna stop here, and I'm gonna say one thing: never drop out. When we say active surveillance, active is what it's all about.
Okay.
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 If they're telling you to come see them every year, if they're telling you to get labs drawn every 3 months or 6 months, always stick with that and be sure that you are active.
Well, the one thing
So
that was really stupid on my part and just completely ignorant is when I had that first MRI and it came out clean and, PIRADS 1, I thought I was good to go. I thought that was it. And it was very, very ignorant on my part. So this is me dropping the ball.
Where were you diagnosed at?
Mayo Clinic, Rochester, Minnesota.
Okay, that's right. You did say you worked there. And we usually think of the Mayo Clinics as being excellent hospitals. Are you happy with your doctor there? Who are you seeing?
Well, my PCP is amazing. I literally love that man. He's great. I have a urologist I've had face-to-face with once, and then after the MRI, he called me and set up the biopsies. I had the perineal targeted biopsies, 15 cores, 6 came up positive.
What are the Gleason scores on those?
4 times 7. 4 plus 3, 7.
4 plus 3, 7.
Yes, times 4, and then 1, 3 plus 4, 7, and 1, 3 plus 3, 6.
Okay.
What
So
are your
the
percentages? Do you know your percentages?
Left lateral peripheral zone 70, or is that greater than? Which way does the greater than go? 75%. Left posterior 75. Left posterior 50 to 75. Or am I reading the wrong percent? Because there's 2 percentages. Is it tumor involvement or percentage of pattern?
More looking for a percentage of the pattern.
Okay, that's what I've been giving you. And then another 75, and then 25 to 50, and then that 3 plus 3, the 6 one is 5%.
Okay. How about, do you have any characteristics that they've named like cribiform or
Nothing
perineal
that I've seen.
invasion?
Nothing that I've seen. Oh, here we are. Yeah, perineural invasion is present on 1, 2, 3, 4 of them.
Okay, Curviform?
You had a second opinion on
No.
those.
I have not, and this just happened on 2/5. No, wait. This is. Oh, hang on. Let me get to the date here. March 9th, 26.
Okay.
Okay. Well, we definitely want to push you in the direction, especially with the amount of pathology you got there, of getting a second opinion. The second opinion information is already in the chat. That's the two little file folders or squares on your right side up there on the screen. There's more than one doc listed in there. Dr. Epstein is one that many of us have used. Dr. Zhao is another one that many of us have used.
Okay.
And I would be very interested to see what a second opinion is on what you're
Anybody
looking at.
that you guys are like, hey, this is go here, go here. One over the other, Epstein over.
If you're going to ask me my preference, I'm going to tell you who I went to, and that was Dr. Epstein.
Okay.
I liked him. He talked to me personally. I enjoyed the conversation with him, but certainly there are other people that carry a very good reputation there. So
I'd go right to that man.
Epstein.
I think that perhaps you and Michael, I think maybe the low and intermediate group would be a better fit for Milton if he's got 4+3s, 50 to 75% involvement. Certainly the pathology is that's an excellent idea, Milton. That's definitely what you want to do.
It's on my list. Definitely on my list.
Yeah, make sure that those numbers are true.
Okay.
Most probably, we have people in the group here that grade low to intermediate grade group 2 with 3+4s with a low volume of 4, meaning anywhere from 0 to maybe 15 to 20%.
Yep.
There's a consensus out there that these people with, being active and staying with it can stay on active surveillance. I don't know. I just want to throw that out there. What the rest of you, what do you guys think? Dan, what do you think?
Which Dan do you want to talk to?
You, sir.
I think Milton is an interesting case. I assume, Milton, you kind of dropped the ball when COVID came out. By the timing, you decided maybe the hospital wasn't the best place to be. And
it was just a combination of things. Losing my partner back in 2016, and then trying to get back out there, and just it was a dumpster fire. So.
Yeah. So I think yours an interesting case. It's the fact that between 2022 and 2026, your PSA really didn't budge. I mean, there's
15. Yeah.
And there's 10 to 15% variability from test to test. So it's really almost the same. And yet your MRI went from PIRADS 1 to a PIRADS 4. That PIRADS 4, now, did they see one lesion or multiple lesions? What did they see there?
Oh boy. Give me a second. I got it right here. That was February 5th. So lesion 1. I only see one lesion.
Okay, well that's good. So they didn't see stuff in both sides of the prostate.
Were all the positive cores from the same lesion?
I believe so. I got the where they came from. Come on.
Because you said you had 15 cores, right?
Yes, six positive, 9.
So positive, they probably targeted that spot.
So left lateral, left posterior, left posterior, left posterior, left posterior, lateral, the apex left, and then right anterior apex had the 3+3.
Oh, so you have cancer on both sides, yeah. So what was the MRI done before the biopsy?
Yes, MRI February 5th, and then the biopsy 4 weeks later.
So yeah, they were probably targeting. So what is your urologist at Mayo suggesting to you?
Tomorrow I have 2 consults: surgical, radiation oncology.
So they're pushing treatment, and how do you, is that what are you comfortable with that?
Absolutely not. I mean, so just history. My brother is 3 years older. Last April, mid-April, he was diagnosed. MRI, PIRAD. What was his PIRAD? 6 or 7?
Didn't go up that high.
Yeah.
And then he went in for surgery in June and had the radical. His PSA did not drop. Then they did the PET scan and found it in his pelvic bone. So having him, I feel like I have a little bit inside information on the surgical side of things. And without getting into any personal information, I'm freaking out and appalled at what they consider prostate cancer treatment in this country or in the medical industry. It's appalling. Appalling. I don't know.
Well, this is not the right group to discuss the pros and cons of the various treatments, but I understand how that would be, how that could definitely rock your boat a little bit. And it sounds like your brother had a very unfortunate situation. They kind of did things bass backwards there, but
They
anyway.
did. Yeah, and one of the doctors actually admitted, he said if we had done the PET scan first, we wouldn't have done the surgery.
Exactly. So, well, I think you're in a bit of a tough situation. I think getting the reread from Dr. Epstein could lower your scores, and you might be able to twist somebody's arm into allowing you to undergo active surveillance. But I
mean, I don't have to be allowed to do anything. I can make the decision on my own.
Right, but you want to do what's smart, right? And I think the key thing about prostate cancer is when it's in your prostate, it's curable. When it's out of your prostate, it's not curable. So just remember that, and
But I keep screaming inside my head, what is life going to be like?
This is where that, as Gary had suggested, that if you also think about attending the intermediate group, you can begin to get some of those guys' stories and their experiences, and see where that is, and listen to them. Very important there that when we're in these meetings that we try to guide people sometimes where we think they need to be, and you're always welcome to talk with us. But I think you might get a lot of information there that we're not able to discuss here.
Milton, I think you also need to get a genomics test, which we discussed, which is like Decipher or Polaris, and also a genetics test to see if, especially since your brother had prostate cancer, to see if you have any of the gene mutations. I think that would probably help guide your decisions too. So
what would that information do? Because I haven't come across that in the little bit that I have looked at.
Do you have children? Let me ask you that. Okay. Well, all right. So
let me help out with this one, Michael. There are inherited mutations that you could possibly have gotten from your either parent. And if you have those mutations, it can influence your treatment choices. And so it's a very simple test. It can be done with blood, but it can be done with saliva. Mayo should have done it, and they may bring it up with you tomorrow. If not, ask them. And it just rules out certain, it rules in certain procedures and drugs and rules out others.
Okay, because I'm familiar with, because of the laboratory I work at and the billing that I do, the different molecular pathology type tests that are done. I see a lot for women, you know, the HER fish tests, because once they have that information,
Right.
specific,
So this is
medications
earlier
that
than
can
this.
actually, you know,
Milton, this is earlier than this. This is, we can get to that. Those are other tests that might be needed later on if it was more complicated, but this is much more elementary. We're looking to make sure you don't have BRCA, you don't have MSH1, MSH3.
What difference does it make having those and not having those?
The difference is that the treatment, they may choose different treatment, number one. And number two, you may need to check for other cancers.
Oh.
Because if you feature,
go ahead.
If you feature some of these mutations, then it puts you at higher risk. If, for example, you feature BRCA, it makes you a less attractive candidate for radiation. Because the BRCA gene weakens the cells, and you're more likely to suffer radiation damage if you carry BRCA. So we encourage everybody to do this test. It used to be available free until the beginning of this year when the clinical trial finished. But this is standard care. The other standard of care that Mayo should already have scheduled is, with that much cancer in your prostate and possibly being 4+3, they should be sending you out for a PSMA test. And that's something they may raise with you tomorrow. Or if not a PSMA test, what we used in the old days back when I was diagnosed, which is a technetium-99.
Milton, the PSMA is the one your brother should have had before his surgery.
Oh, I've had that. The PET scan, right?
Yes. Yes.
Well, it depends. You know, it could be the Mickey Mouse PET scan that Dr. Kwan uses, which we don't care for. Or it could be a great PET scan like the PSMA scan. So, you know, I don't know when you say PET scan, it depends on the tracer that they were using in the PET scan.
The PSMA, they give you a tracer that lights up anywhere the prostate cancer is, Milton. Very specific for prostate cancer.
That's what they were telling me they were giving me.
And what was the result?
No metastasis.
Nothing outside.
No.
Okay.
Let me.
That's good.
PSMA targeted.
Comment, if I might, Milton. The other thing that knowing this genetic information allows you to be more aware of what's going on in your body and what may or may not be a situation where you are more susceptible to certain cancers. So, for instance, if your prostate cancer is a BRCA positive prostate cancer, that means that you're also more susceptible to breast cancer, pancreatic cancer, and a couple of others. Things that you should now, down the road, be more attentive to, just to protect yourself and your health. And those are genetic markers that family members may also have. So notifying a brother or a sister that you mentioned you didn't have any children, so that's not an issue. In my case, I have a BRCA2 positive mutation, and I had my son tested, and he also was BRCA2 positive. So that information only gives you more tools to protect yourself, to watch your own health and that of your family.
Dan, did you have something else for Milton?
Yeah, what I wanted to say about what Ray's suggestion or whoever suggested doing some of the genomic testing is that Milton, right now you're a 4+3, so you're an unfavorable intermediate. But if you send your slides off to Dr. Epstein and he decides you're really a 3+4, then you're a favorable intermediate, and you might be able to chart a course involving active surveillance, unless your genomic scores suggest that you have a high likelihood of this being a more aggressive tumor. So, it just depends on the order you want to do things. I think we all agree you should get a second opinion on your pathology, but it wouldn't hurt, if that comes back and you're downgraded to a favorable intermediate, it wouldn't hurt, or it would definitely help to know some of the information from the Polaris and things like that. So that's something I assume you're seeing some pretty sophisticated urologists and not just some,
I hope so.
Yeah.
Excuse me.
Milton, I would echo what some of the others said earlier, in that where you are, you probably would get better information from the low intermediate than we. I mean, we're not, most of us are 3+3, or some very few 3+4. Where you go into lower intermediate, you're going to get a lot of guys who are in similar situations to you, can probably advise you a lot better than we can. So are you familiar with the low intermediate group?
No, this is the first group I went to. Like I said, I filled out the form with my email address, and Bill that emailed me back, and there was a group Monday night, I think, that I missed.
Yeah.
And
This is a good start. I mean, at least
I called him
you
and he
going,
said,
but I think
said,
I think you're
why
in a
don't you go
better,
ahead and do that? Yeah.
I think you'd be in a better position to listen to the guys in the low intermediate than we can.
What group is this again?
This is active surveillance.
Active surveillance. Gotcha. Okay.
The group that Bill sent you to on Monday night that you couldn't make.
They meet once a month, right?
No, it meets twice a month, and this group meets 4 times a month. But the group that he sent you to was the low intermediate group. So that group is not going to meet again now until the 13th of April.
April.
Okay?
Yep.
Now,
I think I got that in my calendar already.
Right.
I may have.
Now, I'd like to reiterate what the guys have said. Definitely get a second opinion on your slides.
That was on my,
Okay. And get that going as soon as you can. There is a possibility, and I think we've got to be honest, that he could downgrade you, he could agree, or he could upgrade you. If he were to upgrade you, then that wouldn't be the right group for you. Then you would be in the higher group above that, which meets every week. So the result of your second opinion from Dr. Epstein is going to be very influential on how you move forward.
Okay. Is his information only on this chat here, or is there somewhere else that I can get that? The Jonathan Epstein doctor.
You should be able to Google him.
You can Google him
probably
and come up with every bit of that very easily on where to contact him.
Is he
He's in New
affiliated
York.
with anybody?
He's not. He is affiliated with his own self and his own group. He left a hospital he'd been affiliated at I'm gonna say 2 years ago.
He was the senior leader for 40 odd years at Hopkins.
Okay.
And then there were some issues, and he decided to leave, and he went underground for about 2 years, and he's just surfaced he's affiliated himself with this practice in New York, and that's where he's doing the slides. But if you call that number, most of the time he picks up himself.
There's no phone number. It's just his email
Okay.
and a website. But the
Okay,
website,
did-
advancedeuropathology.com.
well, all right, yeah. Usually they. Let me see what's pinned here. Yeah, usually we put a phone number in there. I'll put a phone number in there and pin it up there. But we do often put a phone number in there.
Gary, we probably should grab some guys.
Sounds like a plan. All righty. Cindy, wanted some time?
Is that me, did you say?
Yeah, wanted some time, Andy?
Okay. Yeah, just two things. One was regarding lesions on MRIs. They're not always cancer. So that's one of the important things to remember. I mean, I'm a good example of that because they targeted my lesion and it was not cancer. They had cancer in other areas. So not, you know, and even when you read the report, of course, it's across the board type medicine, you know, check to see by other means because this may or may not be cancerous. So that was the first thing. But I was just wanting to do a follow-up because I think it was 2 weeks ago. I brought up the PCE test, which is also known as the prostate cancer epi-switch PSE test. It's a blood test that combines standard prostate PSA testing with epigenetic analysis, and they improve the accuracy of prostate cancer detection. They claim up to 94%. I will put an article right now in the chat, download, that relates to that from 2025. I think you may want to look into this some more. It's just a blood test. And, you know, they measure, I think, 5 epigenetic biomarkers in conjunction with the PSA levels. And that combination allows for more comprehensive evaluation of cancer risk. Takes about 4 or 5 days. Obviously, it can identify cancer more accurately, might reduce the need for invasive procedures. Medicare does have a code for it as of 2024. I don't know if that changed by now because of all the brouhaha going on with the government. But there was a CPT PLA code, the 0433U, which is used generally for biopsy type genetic.
I'm sorry, what was the name of the test, the three letters?
It is, they have 2 names for it, PCE test, but prostate cancer epi-switch test. So that's what they call it. That's what would be ordered. It's being more widely used. It's still early as far as the evidence base. I think it's been around since 21. There's small studies, you know, relatively small, including
So Andy, if one's been diagnosed already with a biopsy, is that test, what does that do for you?
Well, with all the anxiety we discussed about PSA testing, I don't know if it would help with that anxiety or not, because your point is, hey, I already know I have cancer, so, you know, this
Right.
isn't going to tell me anything new in that regard.
Yeah, and that
Yeah,
link that
that's-
you sent, Andy, that link that you sent is to your download. I put
Yeah, I
the
was trying to,
PubMed.
let me see if I can find, because I
I put the
have,
PubMed link there. I added it to the chat.
is there a way for me to put like a
I already loaded it in,
PDF
Andy.
in here?
I already loaded it in, Andy.
Oh, you got it. Okay.
Yep.
Thank you. So,
Right, Andy,
yeah, I
was
mean,
it-
that's a
was
good
there
point.
anything else? I mean, we appreciate you bringing up another.
No, that was it. I just wanted to update you guys on that.
Okay, well, Dan downloaded that, so anybody interested can, don't forget to download the chat before we sign off, so you guys don't miss it, okay? That's
That's what I was going to mention to Milton. Do you know how to download the chat, Milton?
I do not.
Because that way you're writing a lot of stuff down. You can just download it and everything will be there for you on your computer.
See it. I see it now.
Okay.
And it's done. Thank you.
Okay, Steve.
Yeah, okay, thanks. Hey, just a couple of things, some updates on my world. So it took the better part of 3 months for me to get a second opinion. I started down the road back in October with Dr. Epstein and kind of struck out there, to be honest with you guys, and ended up going to Dr. Zhao, who was very respondent. He helped me work through basically trying to get one hospital to send biopsy and slides to Mount Sinai. He helped me kind of navigate that thing. And I talked to him last week and he was very quick to turn around the results once I got them. And just a little background on me. Originally, I was had a 3+4 with 10% on the 4, a PSA that had moved up from basically the 1s to 2s up to like 3 to 4 from that perspective. And the MRI had a PIRADS 3 on it from that perspective. And prostate was about 46 mils, density was 0.09. And so I was diagnosed originally with the 7, was told I should get my prostate removed. Went down to Fox Chase, Dave G. I know you're in the Philly area. Fox Chase was really good. If you have anything, they were really helpful there. And I'm on active surveillance now. Dr. Zhao downgraded my my biopsies to a grade 6, and there were no PNIs from that perspective, and no crib forms or anything like that. And I had a ton of questions for him. He was really great on answering and spending the time, and very personable. It was a great experience. So that said, I just had a PSA test done a couple of weeks ago, and it's basically flattened out. My PSA is roughly around 4. And I'm going for my 6-month follow-up with the doctor at Fox Chase, Dr. Smaldone. And I just wanted to ask the group, since I kind of have some new information, feeling a little bit better about things, what would be the types of things that I should be considering at this point? I'm glad I didn't go forward with surgery or radiation or anything like that. Dr. Smaldone kind of counseled me, and active surveillance is probably where I want to be. The grade 6 now kind of confirms that's probably the best place for me to be. So I'm just really wanted to ask the group of, what are the types of things that I should be doing as next steps when I have my follow-up with Dr. Smaldone in a couple of weeks?
Number one, you should keep smiling. That's the first thing you should be doing. Keep smiling because it's looking good. Everything that you said, and even at a PSA. Now, how old are you, real quick, Steve?
I'm 71.
Well, there you go, buddy. You got a 4.0 PSA at 71. You got a 3+3 Gleason. Keep on smiling. That's the key. I don't know how the other guys feel. Your 6-month checkup. I don't know what you've been doing with diet and exercise. You can never go wrong there. I'm sure you hear it from the group all the time. Active. You go see them they're doing PSAs every 6 months.
Yeah.
Yeah. I don't think there's anything else that you really can do. An MRI. When's the last MRI?
That was done last September.
September, okay. Maybe an annual MRI. That normally seems to be the consensus now. So you can keep the trend going. Trend is your friend. You know, you get an MRI, they don't see nothing. You go next year, they don't see nothing. Hopefully that's how it goes. But you really just have to, you know, I think all of us would agree that you're in a good place. Certainly a good experience with Dr. Zhao, which is good to hear, especially since we recommend him also. And who else has got some input? What else do you think?
Steve, did you get a genomic test on your stuff?
You know, I have not had a genomic test.
You might ask your guy about getting a genomic test.
Okay.
Where were you?
Sitting on the table outside.
In terms of any of the other things, I mean, I've heard some other things on, like, I don't have any kids, you know, so I'm not so worried about that piece of it. But thing with, like, I've heard the things with the BRCA test.
That's genetic.
It's genetic, so I shouldn't worry about that, those type things.
That's a genetic test.
Any history, any family history of cancer? Prostate cancer?
Sorry?
Any family history? Your brothers, your father, your uncles?
No, just actually grandparents on one side. But yeah,
Okay.
one of them had throat cancer.
Well, that's not really, I don't think that would be a huge concern at this point.
Okay. Well, I thought I'd, you know, take the time to ask and see if just want to go in there with enough information to ask as I go into the next round. With
Excellent. Yep. Being your best advocate, answer the questions. If you have questions, you know, you can have them, put them in your file. That's always good to have them on physical paper and say, yeah, add this to my records. Andy, you had your hand up. You got something for Steve?
Yeah, Steve, how are you feeling just emotionally about having cancer?
Well, you know, I was doing pretty good with it beforehand, even when I was 7. And once I was put on active surveillance, I felt a lot better. And, you know, I don't feel any adverse things. I've been living my life. I'm pretty active. I'm a big gardener. I'll be outside, you know. I've dropped some weight, so I'm feeling good from that perspective. I get out and walk every day. And when I got the 6, it was almost like, wow, you know, it's like there's another level of feeling good, you know, from that perspective. It was a little bit of weight, because I always was second guessing, like, you know, even with, it's like, okay, so now you have 2 tests, so which one's right? You kind of have that piece of it. And, you know, knowing that Dr. Zhao has the street cred, probably, as mentioned on here, one of the best in the country. I think, Gary, you mentioned that, or one of the two, you know, made me feel a lot better about that. So overall, I feel pretty good at this point. And, you know, it is a little bit more weight off my shoulders. There's no doubt about that.
And I was kind of similar to you. And I went and had a PSMA PET scan because I thought, well, if I have to treat for any reason, at least, you know, it'll direct that treatment, because if it's out of my prostate, then it's a whole new world.
Right. And that was one of the questions I had for Dr. Zhao as he looked at the slides. And, you know, he was adamant. He goes, no, there's nothing that I'd say. Now, one of the questions I asked him is, so what is your prognosis not tell me? Okay. And he's, you know, he qualified it saying that, you know, like, hey, it's like we poked holes in a few places. Does that mean there's something else lurking there? There could be. You're just not seeing it, you know? So, you know, there's always that side of it. But he said, overall, I'm probably going to, you know, if I'm going to die from something, it's probably not going to be prostate cancer at this point in my life.
Anybody else have anything for Steve? Any other questions, Steve? Like I said, I think you even when you had the 3 + 4, 10%, that would still put you right here. And having it downgraded by Dr. Zhao, that's, like I say, that's an even better. I'm sure there was a sigh of relief there. So certainly think you've got a good you know, a good grip on it. And you know, come see us every week and let us know what's going on. And everything will be all right.
Yeah, sounds good. And just a shout out to you guys. You know, I've been on haven't been every week here on the Wednesday nights, but I've hit the last couple of seminars with Dr. Epstein and Emberton a couple of weeks ago, and they were really enlightening. So appreciate all the insight that this group's provided.
Yeah, it's always good. Everything is recorded. So if you can't do something on noon on Saturday, a lot of people have things to do on Saturday at noontime. You know, they release them on YouTube, and then then you can watch it at your leisure. So it's, you know, when you're there live, there's question and answer. Sometimes that's really enlightening because the doctor's answering right then and there in real time. But you can always go back and look at it. Andy, you got something else?
Yeah, I went to the, what's it called? Men Speaking Freely group. Bill was in that. I don't know if any of you have attended it, but it can help with any anxieties or other concerns. It has slightly different focus in this group. It doesn't get technical.
Yeah, it's the only
Talk
thing-
about everything but treatment, anything but the disease.
yeah, there's
Well,
the
no,
only
talk
thing
about
about
the disease.
the men speaking freely is a lot of those guys are high risk and recurrent. So you're going to get a lot of that when you go through. There's not a lot of active surveillance guys in there, although Rick would like to see
Right.
more active surveillance folks. I've
But
been to
you know,
several.
anxiety is anxiety about cancer.
Yeah,
Whether you're on active surveillance or you have pancreatic cancer or brain cancer or whatever it may be.
it's a little different when they're talking about hormone therapy, etc.
Yeah, big difference.
Hey, Gary.
Yes.
Why don't you take a few minutes here and update us on what you had?
Yeah, okay. I
What'd
actually
you
was
go
off my schedule. I thought I was going next month, but last week I went up to the Mayo Clinic, and of course, right off the bat, I told them I wanted a biparametric MRI without contrast. So I had already taken my goofy pill, which supposedly has a 30-minute live time. And they say, well, it's supposed to be with contrast. And I said, no, I don't think so. I said, there's some studies out there. They can get a good enough image in biparametric. It'll lessen the time in the tube. And I'm highly claustrophobic. Long story short, they did it my way. They did biparametric, no contrast. I have to be honest about anxiety, what Andy was just talking about. The first 120 seconds I was in the tube, I had that ball in my hand. And I was just really going to press it for the first time. And just a little short story. We had the music. I said, well, each song is roughly 3 minutes. I'll count the first 10 songs and I should be out. So as the music was playing, song number 1, song number 2. Anyway, I made it. It was all good. No lesions. So that's 3 in a row. That they see nothing. PSA density was 0.09. As Dan in San Diego, big glands are like 90. I have 89, so I'm just teetering right there on the 90s. So I'm going to be a big guy. PIRADS 2, nothing, no type of. They didn't notice anything, any kind of invasion or anything like that. PSA went up to about 8.2 from like a 7.6. Not too overly worried about that. Something that MRI, the Mayo Clinic did do on the report that I received on my phone. Now they did this on a Tuesday night. I saw him Wednesday morning. Those results were on my phone before I made it to the hospital. And of course they have 20 tubes. They have a 7T. And they've got something brand new for cancer, some kind of only one in the country or the hemisphere, ion carbon or something like that. I don't know, but they were bragging about that. They have something, they must buy a program called scanslated.com. And what it does on the MRI report itself, they highlight any type of medical term and you just press on it and it explains it. It'll tell you about the PIRADS. It'll tell you about any type of invasion. It will tell you all the different words that they use that you don't understand. You just press the highlighted word, and it gives you like a Webster's definition of what it is, so you can better understand it. I thought that was pretty cool. I don't know if any other MRI reporting is done that way. but it was good. So actually, my question to the group, I guess I do have one. My last my last biopsy was going on 8/16/21. So August of this year, it'll be 5 years. He suggests, he says the normal protocol is a biopsy. I said, I'll let you know. I didn't schedule it. I said, I'll let you know. Right now, he's just got me set up for another MRI next March. So, as I said, I've had
any change in the MRI?
No, 20. I missed 23. That must have been COVID. I can't believe I missed 23. But I had an MRI in 22, 24, and 25.
So they're not showing any difference.
No.
Okay. Is there, Gary, by getting the MRI that you got, which was different than the previous MRIs?
No. No lesions at all.
No, what I'm saying is you got a different kind of MRI, right?
Yes, I did. I got the other ones were multi-parametric. I'm sorry, with and without contrast. Yes, you're correct.
Right. So is there, I mean, I don't want to throw a turd in the punch bowl, as they say. But is there any thought that those kind of results are not compatible? I'm throwing it out to the group. I wouldn't think so.
No, I think that since he's consistent and it's no lesions, no, I wouldn't. No. I wouldn't be leaning toward a biopsy. Like, why?
I wouldn't either.
What's the point?
I mean, if your PSA had jumped 4 points or 5 points, it would be different. But you're barely varying, right, Gary?
Yeah, it's been from the 6s to the mid 7s, then I'll hit a 6, I'll go back to 7. This is the first 8 I saw, and I don't know if my camera can do it justice. I guess not. But any of those words, for instance, exam, clinical history, active surveillance, prostate cancer, PSA, tumor, comparison, volume, density, all of those things you can highlight and they'll explain it to you, which I thought was pretty cool. But no, I think I'm thinking like you guys. Now, as far as me getting a biparametric versus a multi, getting the contrast, we've talked about the gadolinium and about it's a heavy metal and it goes through the brain barrier. And I've read some stuff with Howard on active surveiller. And, the consensus is the doctor down in Miami, Dr. Poonen, I heard his webinar where he said biparametric is more than sufficient for an MRI when you're on active surveillance with low grade that's been historically low grade cancer or no cancer. So that's why I chose not to get the like I say, it saved me about 20 minutes. And he also pointed out it was less expensive. I did not care that didn't matter to me, but he pointed that out. So I'm just kind of thinking, I'm not, and of course we had the webinar about debris, during a biopsy, there is debris as they take the needle out. There is debris. It only makes sense. So I don't know. Right now I'm I don't, I'm not going swinging towards the biopsy. And the only thing I wanted to point out to the group, he was the gentleman, my urologist, that did the precision point transperineal biopsy. There's something new out that he's doing at Mayo called the TP Pivot. It's a new system. It allows for improved anterior access. So evidently, it's a new gadget that they've got. They've gone from precision point to this TP Pivot. That's the new system out there.
But Gary, you don't have a lesion for them to pinpoint.
No. I'm just saying that for people that are interested, if they were looking for like if we send somebody for like a transperineal, I always mention precision point because you only get poked once.
Yeah.
I believe you only get poked once with this particular system, but I guess it's instead of fixed, I guess it's a pivoting type system. and it's improved interior oxygen. That was just general information for the group. And in the future, we can throw that out there to find out if, in fact, if they're going to a center of excellence like, Sloan Kettering or Cornell Wild or whatever, do they have EP pivot point? That's the latest and greatest out there. So just proves how quickly, things change, and there's always new stuff around the corner.
Oh yeah.
Gary, this all is, I think, good news here. Let's try to catch a couple of guys here with
Yeah,
their hand.
absolutely. Go ahead.
Yeah. So Andy, go ahead.
There is a lot of current information comparing biparametric and multiparametric. And often what I'm seeing is biparametric is more widely used with people who do have lesions and targets. And the type of biopsy you had with the trigger with just 2 sticks is also, at least in the research, more commonly used in people who have focal lesions. So I find that interesting. I see Dr. Poonam. He's ordered a multiparametric for me at this point. This will be my first MRI after my initial diagnosis last October. So there is a mixture of information coming out about multi and bi and what they're for, what they do, what they don't do. And he would do on me. Now, again, because I have a lesion that turned out to not biopsy as cancer, he's going to use the other type of transperineal, where they just map me out. So it seems to be a lot of mixed information, and it is still relatively new whether multi or bi are going to give us, because that was Hugh's point, I think, give us similar comparative results. But your PSA is good. You said it was 6 years since your biopsy?
Yeah, it'll be 5 years in August.
So, just so you know, just for your information, there is a lot of mixed data out there on all of this.
Alan, you got your hand up? Alan?
Yes, hi. I didn't realize you said me. No, I just make 2 comments to Hugh and Gary's point. Last September at the conference in New York, I asked the head of Weill Cornell the question of contrast versus non-contrast. He said for someone diagnosed but not treated, non-contrast is fine as far as Weill Cornell is concerned. He said they will see everything they need to see. Maybe if you're dealing with a less skilled center, it would be different, but at Mayo, I would think it would be the same as Weill Cornell, and they say don't bother. I'm scheduled in July for my next MRI at MSK. I asked them, is it contrast or without contrast? They said, no need for contrast. And I do have a lesion. I'm a 3+4. And their attitude was absolutely no need for contrast at this point.
Nice. Glad to hear it, Alan. Thanks.
So I think that's a wrap. Joe, you said you had a story or something like that, and
yeah, I mean, I won't be insulted if anybody tunes off if you want to, but I'll give it as briefly as possible. I've been on active surveillance since 2021, and I've had like five MRIs and 3 biopsies during that span, kind of evenly spaced out. So I recently just had another MRI. And generally, I haven't shown any progression, either radiologically or with Gleason scores, or pathologically. But I was surprised. So I'm an American living on the west coast of Canada in Victoria, and I have been, of course, there. I have been associated also with the Center of Excellence in the U.S. too, and so I had a conversation with my U.S. Urologist. I have a local one, but the U.S. guy is a big shot at University of Washington, and which is a Center of Excellence, and he surprised me by saying, "I think it's about time for you to get treated." And I said, "What?" I said, "My MRIs are stable. Yeah, my PSA's 3.7, but I'm on finasteride, so you have to double it. But I have 100 cc prostate, which means the density is low. It's under 0.1. So everything seemed to be stable. No adverse pathology. My pattern 4 varies by whoever reads it. I've had multiple opinions on it, but Epstein has it at 5%, and other has been as high as 20, in my readings. So I'm between 5 and 20% pattern 4. So anyway, so then I questioned him. I said, "Why?" And he goes, "Oh, well, I think it's about time." And, it just seemed like arbitrary. And so I just wanted to give you guys a bit of, always be skeptical of your doctors and question them. So anyway, because he couldn't come up with a good answer, he said, "Oh, I think you're okay on active surveillance, but get a biopsy because I'm getting a little, nervous about you." And I said, and then, given Dr. Emberton's, view on, I mean, I know he's kind of maybe an outlier on getting biopsies and the potential for spreading your cancer. I know it's not an opinion he would have, but my urologists have. But anyway, given all that, I'm not too. He says, because you could have it either here in Washington or in, locally. Of course, I'd have to get a doctor here to agree to it locally, but nonetheless, I'm just a little skeptical of the process and the urologists.
What you're saying is there's really no new information to change his previous.
Yeah, to me it depends on his mood. Like, last time he was fine with it, and then this time there's no difference. My PSA has been dead stable, like it hasn't moved. I have a decipher score that's kind of low risk decipher score, but I haven't done a lot of other testing. So I said, "Is there other testing like a TRAI or PSMA PET scan or something?" And he goes, "No, I recommend no more testing. Just get another biopsy." And just out of, so I feel like it's a little arbitrary, like, whatever.
Yeah, I think you're right. But how long has it been since the last biopsy? And you've had 5?
I had one in, the last one's 3 years. So it has been 3 years. So I think that's what he's basing it on. It'll be 3 years. But there isn't any PSA or radiological evidence, I think my last.
Of any change.
Yeah. In my health. So that's sort of my little story.
Yeah, I think cross your legs and say you've had enough.
Enough is enough. Yeah, I know I find I want to get poked again because all my biopsies, I've had no anesthetic and they've all been painful to some degree, and especially the last one, which was a ultrasound guided transperineal, was quite painful without any anesthetic. So
did they run out or did you refuse?
No, they didn't offer.
Where did you go?
This is in Canada.
I guess you guys are supposed to be tough from up there.
Yeah, we're tough over here.
Yeah, really. You're real men up there. I ain't lying. Oh, shit.
They say, "What? You want anesthetic? What are you, some pussy or something?"
What are you, some kind of sissy lala? Didn't you play hockey? Didn't you get hit in the head with a hockey stick? Damn.
I'm like Gary. If I could, I'd do anesthetic for an MRI.
I definitely think you should stay the course, Joe. It just doesn't seem
I
Especially
know,
from this guy's
but I
attitude,
don't want
you
to
know.
break, I don't have many US connections, and this doctor, I don't know. I mean, drop him, or my local one doesn't know much about prostate cancer, to be honest. I probably know as much as he
Well, I
does.
don't, if he's that wishy-washy, I guess you say, well, I want to push it another year and see what he says.
Yeah, I think Hugh, you're right. That's what I was going to say. Maybe I'll, maybe later this year, then I'll just kind of push it off. And if anything changes,
Yeah.
if I start getting nervous about the PSA or something.
I know one time when my doc was recommending a biopsy, and I said, well, what if we wait another year? And he said, that's fine. He said, and I'll continue to be your doctor. He said, if you were wanting to ask something that I really am not comfortable with, I would recommend you get a different doctor. But he said, no, that's within the realm. So, they do kind of put things out there, and you push back a little bit, and they don't always have a real good reason. And what do we know about this? All of these treatments, there's not all of this stuff with prostate cancer, there's not such definitive stuff. So you push back a little bit.
And I think also the urologist has a bit of a bias. I mean, even though I told him I would go radiologically if I was going to get treated, but I think they have a bias towards treatment. They just want to be safe.
Yes,
I agree. And
even if it isn't him doing a prostatectomy or something, there's, because he's always said this. Like the first time I visited him, he said, "Oh, I think you should get treated because the NCCN standard, the one standard I didn't meet was more than 50% of the cores were positive." And I said, "Well, I had a targeted biopsy, so of course I had a higher." And then so he goes, "Well, you're over the NCCN." He was very NCCN literal, and that was the only thing that I wouldn't qualify, as far as NCCN. But I find that whole thing was kind of arbitrary too, that because the very next biopsy, they did the targeted, and then they did some samples, and I got my percentage below 50%, and all of a sudden I'm in the NCCN because
There's a lot of gray areas. There's a lot of gray areas and all that stuff. Even my guy,
you can't take those standards. They're just kind of standard.
According to the guidelines, you should get a biopsy, and you could tell by my face and just not by my, oh, well, let's schedule it. But that's, like you said, he just kind of said, okay, that'll work. I'll review him next year for an MRI.
And the worst thing is my wife was, I had to go to get this phone call. I had to receive the call in the US. So I had to take a ferry to British Columbia, to the mainland, and then go to Point Roberts, which I don't know if you know about the geography. It's this little piece of America off of Canada, surrounded by Canada. And I went through customs there, and then I get on the call, and my wife's in the car, and then as soon as he says, "I think you should be treated," she gets wild, So it wasn't a good.
Yeah,
it was a full day of travel, about $250 in charges, just to get the 20-minute phone call.
Have you heard of a VPN?
Yeah. How does he know where the call is? I would have sat there and said, "You bet. I'm sitting here in New York City. Go ahead."
His office in the portal says you must be, they gave me all these warnings. Now, I don't know what, I have a US phone, but I guess it connects to a Canadian tower, they could, if someone went through this big investigation, they could figure it out, but how would they know? I think I should have just stayed in the US and not just told them I was there.
I don't, yeah, I know. I think I got a call one time, and they said, "Are you in the state of Texas?" I thought, oh, come on. Is that an actual place, or just a thought, right? What is
All right,
that?
Andy, you got your hand up. You got something quick for Joe?
Oh, I just thought, sounds like a urologist getting cold feet. I mean, he just is. He's something has him nervous. Either he's in the middle of a lawsuit, perhaps, not necessarily related. And yes, he is a urologist and he is a surgeon, and surgeons do surgery. But I don't know, it doesn't, something just doesn't feel right there.
I think he's always had that bias, even from the very first meeting I had as treatment as the first option. And then I have to talk him down, then he usually agrees with me by the end.
Well, remind him whose plumbing it is he's talking about working on.
I only had 2 cores positive, and my urologist wanted to treat because one of the cores was 60%, and he quoted the NCCN guidelines. And I think urologists feel safe when they can stay with quote unquote within the guidelines.
Yes, yes, he's very
NCCN. They kind of get because they may feel that they're opening themselves up to litigation. Nobody wants litigation. So
well, and I could see the point, Dan, that they bring it up, you push back, and then they can sit there and say, okay, I brought it up to the parent, the patient, and he didn't want it.
Yeah.
You know, and that they don't really feel that strong. So you push back a little bit and away it goes. So listen, guys, I think we got a wrap. Joe, it's great to see you. We haven't seen you in a while.
Good for seeing
Don't forget to download.
So yeah, thank you very much. Get your downloads saved. Excellent. All right, guys, moderators, why don't we stick around for just a few minutes?
Roger.
Thanks, guys.
All right. Good luck.